Good morning, everyone. Welcome to the AMA's Telehealth Immersion Program mini boot camp and happy Telehealth Awareness Week. My name is Stacy Lloyd. I'm the Director of Digital Health and Operations at the AMA and will be a bit of your MC for the day as well. I do have a few colleagues here that will be available if anyone needs any support. Laura Fritchie and Audrey Jai can help with any technical questions and will also help us get situated into the breakout rooms later in the program. So you can message them directly through the chat, or just if you have any questions, feel free to use the chat to get those answered. A special thank you to the American Telemedicine Association for hosting the first annual Telehealth Awareness Week, and we are really excited to be collaborating with them on this boot camp to close out the week with the event. A few additional housekeeping items before we get started. This event will be recorded. We are running this as a Zoom meeting, so we do ask that if you are not speaking to please mute yourself, but do feel free to leave your video on if you feel comfortable doing so. If you have any questions throughout, please feel free to put them in the chat and we'll get to as many of them as possible. And there will be time for additional live interaction and discussion in the breakout rooms later in the program. Next slide. I'll pause for a brief moment here just to share our standard AMA disclaimer before we get started. All right. Next slide. So I mentioned we have an action-packed agenda today to wrap up Telehealth Awareness Week. We are really excited to have some opening remarks from Dr. Joe Kvedar. We'll be doing an interactive panel discussion focused on health and hospital at home, representing a variety of crucial industry perspectives. And then we will also be doing some breakout sessions to allow for additional engagement and dialogue across a few different topics. So let's go ahead and get started. Next slide, please. Unfortunately, Dr. Kvedar couldn't be here with us today due to a conflict, but we were thrilled to be able to get the opportunity to record some opening remarks from him just a few days ago. Dr. Kvedar is a professor of dermatology at Harvard Medical School, chair of the board of the American Telemedicine Association, and editor-in-chief of NPJ Digital Medicine. At Mass General Brigham, Dr. Kvedar has focused on driving innovation, creating the market, and gaining acceptance for telehealth for nearly 3 decades. And now he's applying that expertise, insights, and influence to advance the adoption of telehealth and virtual care technologies at the national level. So without further ado, let's officially kick off this morning's programming with Dr. Kvedar recapping the week's events and sharing some insights on the impact telehealth has had over the last year and a half, and really the future of virtual care moving forward.
Well, thanks for inviting me to kick off this amazing telemedicine boot camp for my friends at the AMA. I'm delighted to be able to give some perspectives on Telehealth Awareness Week, and also talk a bit about just how telehealth has evolved over the last 18 months, because indeed it's been somewhat of a roller coaster. The pandemic has in so many ways, but some interesting aspects of how telehealth has come to the fore, how our patients are viewing it now, and some of the lessons that we can take away from this exciting time that we're in. And indeed, the first thing I want to mention is Telehealth Awareness Week. I know we've just concluded that. The good news for you, if you weren't aware of it, and I hope you were, because it's been all over social media, but the good news for you, if you weren't aware, is that you can go to the website, and you see it here, telehealthawareness.org. There's lots and lots of content that is on demand that you can still pick up and watch and learn from various webinars and things that have been done over the week. I think our main objective in Telehealth Awareness Week, to be honest with you, was to try to get as much attention paid mostly on the policy level. It never hurts to get consumer awareness and patient awareness, et cetera. But we really wanted to engage our colleagues, and particularly in our nation's capital. And we were very successful in pulling together over 65 congressional leaders to sign on to a resolution that was bipartisan in nature and passed just a couple of days ago. And I know that's symbolic, but I do think given everything that they're dealing with right now, it doesn't hurt to remind our elected officials that this is an important mode of healthcare delivery going forward. And because it's bipartisan, it's something that they can all agree on. And there are some important legislative things that we need to tend to, which I will get to in a moment during the presentation. So all in all, I think Telehealth Awareness Week was a success. We'll know more as time goes in and we measure more about some of the engagement we've had with our platforms and so forth. And we really do thank ATA, that is, really do thank the AMA for inviting us to be part of this special boot camp that we're involved with today. So again, this is just a reiteration of what I said, mostly about Telehealth Awareness Week. It's content that I would hope you wouldn't read now because I want you to listen to me, but it's there. And again, the website, telehealthawareness.org, lots and lots to learn there if you get a chance to visit. So question one for our time together is really this. We've seen a lot of sort of pundits talk about telehealth. Where's it going? Is it a pandemic only solution, a flash in the pan? And I'd like to address that now. So I've pulled data here from a website called fairhealth.org, otherwise affectionately known as the Fair Telehealth Tracker. And they track all submitted claims that come into our various health insurers. I believe it's only commercial. I don't believe they track government claims as well. But nonetheless, every couple of months they upgrade it. And remember, with commercial claims particularly, you're always a couple of months behind. So I have data through June. That's the most recent data because they're still tabulating July and August, for instance. But I think there are two stories that are told in these two charts. The first one on the left just tells the story of the boom in activity that happened during the first 3 months of the pandemic, March through June of 2020. Remember, claims lag by a couple of months, so August data would be about June-ish. And sure enough, we're up to 6%, 7% of claims during that time. And then compared to August 2019, when it was just, 0.17, I think was the number. So then we look at this year, 2021, on the right-hand side of the slide, and you can see there's this slow decline in percentage of total claims. Now, as you know, now we have something that I affectionately call two-channel healthcare delivery or hybrid, and doctors are able, in most cases, to bring patients into the office when they need care. There are still some pockets in our country, sadly, that are overwhelmed with COVID patients and are having to choose between doing things for folks that are well, or rather not COVID sick and COVID. But for the most part, people are coming in. So in some ways, it's not too surprising that you see this drop off from 7% in January down to 4.5% in June. But there's another story to tell, and the next slide goes over that. Now, this isn't an apples to apples comparison, so it's not the kind of data that would stand up to close scrutiny from peer review. Nonetheless, I think it's interesting, and I think a story can be told. This is data from a large national payer. My colleague there asked not to be named and asked for the company not to be named. So for whatever reason, they feel this is sensitive. But this individual did say that I could share this information with folks when I'm out on the stump. And what this shows is for that one payer, now again, it's a very large one, so I think their experience is interesting, and it might just be generalizable. Nonetheless, you can see if we look through April, 2019, 2020, and 2021, and we look at two groups. Local providers are people like me, taking care of my patients by telehealth. National providers are the Teledocs, the Amwells, et cetera. And I'm sure most of you know they usually work through relationships with health plans and employers to provide these services to people who are employed typically through the workplace. And I think what's interesting about these numbers is you can see that between, again, April 2019 and April 2020, the dramatic change, local providers in April 2020 accounting for 96% of all claims compared to 7% in 2019. And I could see the math on the top one is wrong as well. It's 7%, should be 93% on the right. I'll have to fix that, it's a typo. But the most interesting one, I think, is in April 2021, when you can see that the market share, if you will, of the national providers is going up. Now, the other thing I'll say about the last two rows in this chart is that during both of those times, telehealth volume in general was way up. So it's interesting that when the national providers only had 4% of total claims, their volume was still way up. So that just tells you during April 2020 how much telehealth was going on. In April 2021, this more or less, I think, stable now hybrid world is that. So I think what this tells you is these two slides, that telehealth is not going down, that there's a market for it, and it's actually stable or increasing. But what really, and I think this is a good message for all of the physicians in the audience and others, but is who is going to deliver those services as we go forward? I'm going to come back to that question in a couple of minutes, but I think it's really well worth pondering. And I also think it's the main point I want to get across for you today. It's this notion of, do we want our future to be our own doctor providing these telehealth services, or do we want to go through a third party? The good news is you'll have access either way, but I think we as patients and consumers have to ponder how we want that to go. And I think we have a role to play in making those decisions, or at least influencing them. Now, patient enthusiasm, again, I share this slide because this is why there's a market. 83%, this is from a survey that was done by a group that ATA participated in, run by the Mayo Clinic and the MITRE Corporation. But you can see the numbers, 83% of patients surveyed good quality visits, 78% had their health concern addressed, et cetera. 83% said their provider had strong communication skills with them. So there's a lot of positivity in that. In fact, the other one that I like to bring out is from MedPAC. I know my friends at AMA know MedPAC well. MedPAC is an organization that provides advice on coverage to the Centers for Medicare and Medicaid Services. And historically, they've either been neutral or negative on telehealth. And even they, in their most recent publication, had to admit that 90% of Medicare recipients were satisfied and 67% extremely satisfied with their telehealth journey. So it's that force of both volume of effort and enthusiasm from our patients that has, I believe, cemented us into a future where we will have more than one channel for healthcare delivery. Right now it's two channel. I like the term from marketing omni-channel. You can think about other ways that you might be able to get these services in the future. But nonetheless, I think this is a milestone. And indeed, telehealth is now a household word. Every time I mention to a patient, would you like a telehealth follow-up? They know exactly what I mean. It's extraordinary. And of course, we've brought the doctor's office into your home. Again, non-trivial thing to be able to say that. And for all of the negatives and things that the pandemic brought upon us, this is certainly one bright spot, is that we now have an opportunity to extend access to healthcare, to our patients, through a completely different mode. I think will continue to exist. Now, however, there are some challenges. And some of them are mentioned here. It's not, I would say, natural for our healthcare provider colleagues to simply set up what we call a hybrid environment. If you think about it, there was always one channel before. If you needed help from your doctor, you went to visit your doctor. So pretty straightforward for scheduling, office logistics, etc. Now, which patients do we send to telehealth? How do we manage them? How do we staff that? Do we need different overhead calculations because telehealth is done in a less resourceful environment, like in my home, for instance? All these questions are still on the table to be answered. And it's challenging. The other thing that people may have forgotten is that during those first 3 months when telehealth soared, March through June 2020, most of us healthcare providers lost a lot of money and unsustainable amounts of money because we couldn't do things that we normally do in the hospital to help our patients, but also bring in revenue like transplant surgeries, brain surgeries, cardiac caths, et cetera. And so we are, for better or worse, tied to our brick and mortar. Now, some of the new entrants, the Amazons, the Best Buys, the CVS, are not tied to brick and mortar, at least not the same way we are. Will that give them a leg up in this new digital first world? Well, we'll see. It's an interesting question to ponder. But we have not deliberately, partly because it was thrust upon us so quickly, but partly because we're so used to being brick and mortar based, we've not deliberately thought about how to do hybrid. And all the things listed on the slide are important to figure out for that. I'll just mention a couple things here. New roles, the idea that sometimes we have nurses doing work that used to be done by patient service coordinators because a clinical eye is required to make say a triage decision. Sometimes we have them checking images. In my field in dermatology, patients send images. The nurses check them all before I even look at them so that they know they're in focus, et cetera. So these are new roles. And as we scale these operations, we have to think about, is that the best person to do that job? Could we have a less trained person do it? Could we have software do it? Those are all important questions. Again, none of them really have been answered at this point. So what are the business implications of this crazy new world we're in? Well, I've talked about some of this, but for providers, we really are needing to think about how we optimize the use of our brick and mortar all of a sudden. Never had to think about that before. But if we have office buildings that are only half used, that's, as with anything else, if you have an asset, you have to use it to pay rent on it, et cetera. We don't want that overhead calculation to get skewed. So we have to be really thoughtful about what we do. If half of our workforce can be working from home at any given time, doing telehealth in the future, how is that going to impact the way we think about using our clinic space and our hospital space? Now for payers, it's a moving target. And one of the challenges about where we are today in terms of planning for this future is that we healthcare providers are not sure about how we're going to get paid for these services after the public health emergency is over. And that makes it hard for us to do big investments in new systems and new strategies without that certainty. On the other hand, the payers think maybe telehealth offers such an powerful access point that patients might overuse it, that we might have higher utilization. They're pretty afraid of that. And a lot of them have said they're going to ratchet payment way back because of that. So stay tuned on all those as we look forward. But there's no question at this point in time, when you think back on the last 18 months, it's our opportunity to change completely how we deliver care. I would urge you not to think of virtual video visits as the sky or the ceiling or the vision, but as the floor and the beginning and the first step into what I would call a real hybrid world with digital first, with digital tools for our patients, where patients instinctively turn to a digital device when they need healthcare and go from there. And we're a long ways from that. So we have a long ways to go to get to realize this vision, but I don't want us to think we should be stopping because we've achieved widespread adoption of virtual video visits. So it's hard to plan strategy. There are so many unanswered questions here. It's for sure telehealth here to stay. As I alluded to earlier, is that service going to be brought to you by your own doctor? Or will it be brought to you by something that comes through your health plan that's through a national 50-state network of providers? I don't have a quality judgment on either one. I want to make that clear. This is not a diss on the teledocs and the American Wells. However, it does create a potential fragmentation of care that we would need to address. When will the public health emergency sunset? The latest news I have on that is the healthcare regulatory relaxations that we're enjoying from a telehealth perspective will probably be around for another year or two at least after the PHE sunsets, because Congress wants to study just how that affects both healthcare delivery and cost. We didn't really talk about value-based care, but I'll simply say that value-based care really is a tool or a mindset, I should say, that brings all these tools into sharper focus. So the more we can say we're going to get to a value-based care strategy for reimbursement, the more likely telehealth will take off. Remote monitoring is right around the corner. Again, didn't talk a lot about that, but just to suffice it to say that it's primed and ready to take off. And we didn't talk about AI either, or digital therapeutics. Those are on the horizon, really interesting new ways of delivering care as well. So I hope this was helpful. I want to leave you with a call to action though, because so many of these talks are about sort of state of the art, and thank you very much. You have a role to play. You have a role to play as a patient and as a consumer of these services. And if you had any experience on the patient side with telehealth during the last 18 months, and you thought it was of convenience to you and useful, you must act. First, write to your elected representatives and tell them we have to continue offering this to our patients. There is a grave danger that if we don't do something, Medicare will be stripped of its ability to allow us to bill them for these services. We have to act. If you're on the younger side and or employed, make sure your employer and your health plan know how powerful you think telehealth is. And if you're one of those people who thinks it should continue to be offered by your doctor, let them know that too, because their reimbursement policies will be a big lever that will enable doctors to participate, or if not, you'll be invited to come into the office, whether you're better off for telehealth or not, because of some of those restrictions. Thanks again for inviting me. Thanks for listening. And I'm very appreciative of the opportunity. I, again, want you to remember telehealthawareness.org and all the good stuff on our website. And these are my contact information, which I'm happy to share here. And if you want to link to me or email me, feel free, and I'll be delighted to connect with you. Thank you.
We are thankful for Dr. Kvedar to give us this time today. That was an amazing presentation, really awesome opening remarks and great comments, and a real call to action for the industry and everyone here with us today to ensure the progress that has been made with telehealth over the last year and a half doesn't regress. Now we are going to move into
Thanks so much for inviting me to
having a few technical issues. Okay, Laura is going to pull up one slide, just a quick overview, but we are going to move into our panel discussion for today. We'll be exploring the health and hospital at home strategies that are leveraging telehealth and digital health technologies to expand care outside of the health system and into the patient home. We have a diverse panel of perspectives and stakeholders to share best practices, what's working well, and really what the opportunity areas are that will impact health at home and care delivery in the future. Dr. Jennifer Joe will be our moderator for today's discussion. She is the CEO of Vanguard Health, founder of MedTech Boston, is a member of the Massachusetts Medical Society IT Committee, and is a practicing emergency room physician in the Boston VA healthcare system. Dr. Joe has been dedicated to the digital health and telemedicine community for 10 years or more, and we are really excited to have her here with us today. So, Dr. Joe, I am going to let you take it away.
Hi, thank you, Stacy, and thank you to everyone for joining us today on this Saturday early morning. I'm really delighted to be here with a great group of panelists. And today we are discussing the health at home model and strategies. So as our panelists funnel in, I thought we could just kick it off with some introductions and then move into what is health at home and hospital at home. So let's go ahead and get started with some introductions. David Barden.
Sure. Thank you, Dr. Joe. And first of all, happy Saturday to everyone on. Thank you to the AMA for the opportunity to present this morning, share insights, and really bring awareness to telehealth. My name is David Barden. I lead commercialization at TytoCare. TytoCare has really brought a lot of the capabilities to virtual medicine that you wouldn't have traditionally seen with just baseline audio visual. So we have a medical device that can pair into a virtual exam. I'll go ahead and actually show you the device itself. It fits right into the palm of your hand. It's quite small, and it has a lot of the capabilities that you would typically see in the in-office examination room, like the ability to bring a stethoscope into the household to examine heart, lung, gastrointestinal sounds. We also have an otoscope for ear or nose examinations. It actually has the industry's first flexible tip, so it's really easy to navigate that into your ear or your child's ear. We do also have a tongue depressor attachment for throat examinations. The actual examination cameras on the back end of the device with 2 LED lights on both the left and the right hand side for external imaging and algorithmic lighting. And we do also have a built-in IR thermometer for temperature, and most recently an added pulse ox to the kit. So it's been quite fun bringing this product to the market. We've been doing it since about late 2016 when we received our FDA clearance and approval in the US. And I will say that to a lot of the points that Dr. Kivadar talked to, it's been really interesting to see how a lot of the healthcare industry really brought telehealth into the market, primarily to check the box a lot early on in the beginning to really just offer telehealth in general. But now we're seeing a dramatic shift in the market and how telehealth can really wrap around a healthcare system's ecosystem and how ultimately all of care delivery can be offered through virtual means. So really looking forward to the discussion today. Thank you. Thanks
for the introduction. Next, we have Mick Connors, Dr. Mick Connors, CEO and founder of Anytime Health. Dr. Connors, I heard your story. I was hoping maybe you could tell the story of what is Anytime Telehealth and the focus on pediatrics and what you're hoping it will accomplish in terms of closing the gap in the care for pediatrics.
Yeah, Jennifer, thanks. And thanks for the invitation to be here today. It's exciting to further this discussion. I guess I'm old and I'm old school, so I really got into telehealth for probably all the reasons that I got into medicine, which is how can we foster relationships between patients and their trusted providers. So when I work in the pediatric emergency department and see so many kids going to retail clinics and urgent cares and see the disparity and equity of care, my goal 5 years ago was to see, to Dr. Kavadar's point, how can we mobilize the existing pediatricians and physicians to care for their patients and stay connected via telehealth. So that's really kind of the mission as I see it, and I see the value of telehealth as being a connector. I told you this story. I'll just give you my little anecdote of my inspiration was, I've done a variety of things in pediatrics and left the ER for about 8 years doing pediatric sedation, came back to the ER. And one of the first patients I'd seen, I saw in the emergency department was a 27-year-old mom who was there with her 2-year-old son with no chronic conditions and had been seen close to 30 times in the emergency department. And so I kind of sauntered into the room thinking I could, solve the world's problems for this mom and say, hey, why are you here? You've been here so much and your child doesn't have any chronic conditions. And it kind of was like she knew I was coming. She looked me in the eye and she said, Doc, you just don't get it. I work Monday through Friday, 9 to 5, a minimum wage job. If I leave work, I don't get paid. If I leave work, I might get fired, and I go to a community health center that's available Monday through Friday, 9 to 5. So to me, telehealth opportunity is access for folks and access to those trusted providers that they need, because that child needs more than strep tests, right? It needs to be able to be tested for autism and developmental screening and continuity of care. So anyways, long-winded answer to your question, but I think for me, it's all about the relationship.
Absolutely. I really appreciate you sharing the story. And I think it just underscores the importance of going to the patient, meeting the patient where they are. Dr. Kvader saw this a long time ago, which is the connected patient. And how can we leverage the technology that we have in front of us, which is telehealth, virtual care, remote patient monitoring. And we're going to talk more about this hospital at home. How do we do that well? What do we need to do that well? And then how do we make sure it can close the gap in healthcare disparities while we're doing it and give patients a better experience? So with that, I want to go ahead and hear from Stacy Lloyd, the Vice Chair of VHL. And Stacy, you're really giving us a nice and different perspective on this panel, which is very important when we have these discussions, especially as part of the AMA and with clinicians, which is the patient perspective. How has this helped patients? Why is this important for patients? So maybe you could tell us that and a little bit more of what VHL Alliance Board is and what you do there.
Sure. Good morning again. I introduced myself earlier, but I'm really excited to participate on this panel and take off my AMA hat a little bit and channel, like Dr. Joe said, my role as a patient advocate and a patient of a rare disease myself. So I actually have a rare disease, which led me down this path of patient advocacy called VHL or von Hippel-Lindau. And patients with VHL are prone to tumor growth in up to 10 different areas of the body. So as you can imagine, that requires pretty coordinated care. And also because it is a rare condition, a need for physicians that are familiar with the disease and can manage symptoms across multiple systems in the body. So above and beyond kind of, I think, generally what we often hear is kind of the benefit to patients being around convenience, creating access, to Dr. Connor's point. It has been incredibly, helpful and powerful for patients with rare or chronic diseases to access care from specialists outside of their geography, where they may live or not have access to physicians that are familiar with the disease that they have. And also just to be able to maintain those relationships with those care providers, again, that aren't necessarily close to them or around them. So telehealth and virtual care it can be incredibly impactful for all patients, but of course, from my personal experience, it's also been a powerful tool to connect physicians and patients that aren't necessarily close to each other, but there is a level of expertise to manage and kind of treat that care. And again, with that situation, it's also very costly for patients to have to travel and try to seek specialists that are maybe within driving distance, but maybe not, and they have to go fly or stay. So there's that element that really helps when you can maybe receive some of that care locally, or do some of your imaging or testing or labs and things like that local to your community, and then have your physician that is a little bit further away be able to access that and talk you through it via telehealth or virtual care visit. So those are just some of the examples. Look forward to sharing more, and really excited to be able to participate in a little bit of a different way on this panel today.
Oh, thank you, Stacy, for that. Really important to have your perspective. And I think that just underscores what Dr. Kvader alluded to, which is bringing specialists closer to the patient, the importance of the patient-clinician relationship, and really allowing digital to enhance the relationships. With that, I'd like to hear from Dr. Steve Oman, cardiologist at Mayo Clinic. I missed our prep calls. I don't know that much about you. Sorry about that. But my understanding is that Mayo and cardiology, I have a textbook with the cardiologist and Dr. Kvader about this, has been doing it for some of the longest time out there. So I'd love to hear more about you and what Mayo's been doing in your perspective.
Sure. Thanks, Jennifer. So my name is Steve Alman. I am a cardiologist at Mayo Clinic in Rochester, Minnesota. I'm also the medical director for consumer digital products and platforms for Mayo Clinic. And the history of Mayo Clinic is, as you and Joe talked about, is we started years ago with an e-health platform that was largely patient portal and how to get open notes to patients and access to their digital images, et cetera. And then Mayo realized that we had a number of clinical departments and divisions who were working on telehealth related projects. And they were duplicative, uncoordinated. At one point, we had a dozen different video telemedicine clients in use at Mayo Clinic. And so the Center for Connected Care was envisioned to take those projects, coordinate them, and then turn them into products and programs that could be scaled across 3 large geographies: the Midwest, Florida and Arizona campuses, and across highly specialized care, as well as the 60-some community clinics that we serve, and try to coordinate across those. And that's what we did. And now that's grown into something that we call the Center for Digital Health, which is reaching out not just to patients who have medical record numbers here, but patients for whom we can help their health and wellness. And my journey into this space is somewhat parallel to Stacy's. So my practice is a very specialized practice with a disease that is not that common. And so I had patients seeing me from around the country and around the world. And it became pretty apparent to me that patients were traveling back to this small community in the Midwest to see me, when oftentimes I could have provided them guidance along the way without them having to pause their life to get their care and guidance from me. And that's where my first interest came in, and then why I was selected to help lead this Center for Connected Care and now digital health approach at Mayo Clinic.
Thank you. I think that's so important that you were one of the early pioneers, and connecting to patients with your expertise around the country and around the world. Mr. Ryan Raising, AVP, I don't actually know what that stands for. I'm sorry, Vice President, Vice President for Coordinated Care and Post-Acute Care at VCU Health, which sounds like it's got a rocking program that we'd love to hear about.
Yeah, good morning, Dr. Joe. Thank you, and good morning, everyone. Pleasure to be here. Thanks for having me. I am the Associate Vice President for Coordinated Care and Continuum Integration. And VCU's a 3-hospital, about 1,000-bed 3-hospital system based out of Richmond, Virginia. And our journey into home-based and virtual models of care really began years ago. In fact, we've been doing home-based primary care since 1984 for patients with multiple chronic conditions who had trouble accessing the office. We then evolved into a nurse practitioner driven home-based model of transitional care 10 or 15 years ago. And most recently, over the last couple of years, have stood up a pretty robust transitional remote patient monitoring program, really focused on managing patients coming out of the ED or the inpatient setting. And our value lever over the years really has been not only to try to improve patient care and patient-centeredness of our care, but also access issues that others have alluded to here. So, at our quaternary academic center in Richmond, we've got capacity challenges. We're always trying to figure out how to get more patients in than we have beds. So, looking at alternative models of care. And then we've got a couple of rural hospitals underneath our health system as well, which, create their own access challenges. And so I have the good fortune of helping to lead our VCU Health at Home division and our transitional remote patient monitoring programs. And I look forward to speaking a little bit more with you about it today. Thank you.
So I'm just delighted to have such a great group with us who has such expertise in health at home and hospital at home. And I think we are already getting a lot of questions from the audience, or comments and questions. I'm the chair of the IT medical committee, and I do like how these are such robust questions. And I'm seeing some of them coming in, and agreed. This concept of virtual care encompasses a lot. Synchronous, asynchronous, video, telephone. It's really great that we're having nice compensation for telephone visits, the concept of email communication, the concept of text communications. So with all of that to talk about, I want us to be able to kind of get into the meat of a few things. So I think Dr. Vader launched with telehealth. We know that remote patient monitoring has really been an extension that we've talked about. The AMA has created some nice CPT codes to support remote patient monitoring. And the newest thing that we talk about is hospital at home or health at home, which is, and I think we should maybe just talk about that, get an understanding of that, and understand what that means. And we have, Dr. Oman and Ryan Raising. Maybe we could start with Dr. Oman in terms of what is hospital at home for Mayo, or what have you seen and what has that shift been?
Well, I think there's a spectrum, obviously. So we talk about, I'll say health at home and not just hospital at home, because I think it spans the whole gamut from what we all did on a year ago, providing ambulatory visits to patients in their homes or offices, wherever they happen to be, was part of that. And as Dr. Kvedar alluded to in his opening talks, he didn't talk about remote patient monitoring, and we've been doing that quite a bit. And that spans a spectrum to some facilitated self-care products we have, where patients get daily reminders of medications, some just-in-time education based on how they respond to questions about symptoms or their status, the ability to activate a higher level of care if they're kind of deviating from their path.
And could you be more specific on which programs those are? I work for the VA, and we have, a high touch cardiac program and a high touch high risk lung program. But so where have you rolled out those programs, and what are these just-in-time devices?
Yeah, so the facilitated self-care interactive care plans, we actually have about 20 of those that span things from migraine headache management to diabetes management to preparation and recovery from total joint replacement. So it spans the gamut. In the middle is the more traditional remote patient monitoring activities of chronic care management for things like heart failure, COPD, asthma, hypertension, or just a complex care patient, patients that probably are at higher risk for hospital admission. And we showed in a 6-month study within our system that patients on that program had 50% fewer 30-day readmissions because they were being monitored by a team of nurses that could, my vernacular for this is it's like lane drift detection in your car. This is health drift detection for the patient in their home. And it's easier to intervene sooner with a lower touch correction than it is to wait for them to totally decompensate and show up in your emergency department. And then at the far end, at the beginning of your question, we have what we call advanced care at home, which really are patients that otherwise would be in the hospital. But now they have devices, pulse oximeters, cardiac monitoring devices, et cetera. But we also, in that extreme version of that, also have staff that goes into the homes to administer intravenous medications for those individuals. So that really is displacing people out of the hospital into their homes, where they can be surrounded by their own personal support networks and caregivers. And so I think that is at the far high end of the acuity scale.
Thank you for explaining that wide range of very advanced and innovative programs that you have at Mayo. And Ryan, I was hoping to go to you because you guys have such a robust program, and what it looks like for you, and if it does or does not differ from the Mayo experience.
No, I think it's very similar. Dr. Oman's correct. It's a spectrum of interventions. And so we look at it as basically a hospital without walls. It's any care that's being delivered to the patients versus the patients coming to us. And some of that's, sort of more traditional modalities like home health and hospice, but then, some of the things that Steve described. So how we've organized at VCU is we have a group called the Continuum Integration Center, which is essentially the navigation hub for the health system for these interventions. And then, that's the hub. The spokes are a variety of different interventions. So we've got programs where we're sending pharmacy technicians into the homes for patients who are high risk after discharge. They're doing med rec education, filling any discrepancies that might be out there. We've got health coaches that are, sort of laymen's that are going into the homes and helping to make sure patients understand their care plans. They've got access to appropriate phone numbers and the rest. And then, increasing intensity from there, mobile imaging, mobile urgent care. So, we can try to intervene sooner, as Dr. Oman was mentioning earlier. And the purpose of the hub with all those spokes is to be that connector. And so, for example, if we've got a home health nurse out in the home who's seeing the patient and they feel like, something's a little off, we've got the ability to either send an MP out there. We could send out our mobile imaging to do a chest x-ray, some low level imaging, things like that. So the idea of connecting these services together in a spectrum fashion, I think is where we are. We've not gotten to the true acute care at home yet. We are looking at that. I know Mayo's a little further along than we are in that, but at the high end of the acuity curve, you've got the acute care at home and even skilled nursing facility at home these days. But I think it is much more than that, when we're talking about healthcare outside of the walls. And I would just add, we've seen similar impacts with our remote patient monitoring program. So we do have chronic diabetes and hypertension monitoring. We also have what we call transitional remote patient monitoring, as I mentioned earlier. So that's patients that are coming out of the hospital or the ED who need additional support. And what we've seen is a reduction in the hospital length of stay prior to the patient's discharging. We've seen a reduction in readmissions. In some disease processes, pretty significant. We saw 63% reduction in readmissions for our sepsis patients, for example. But the other thing that I think
impressive on sepsis.
Yeah, very interesting. And the other thing I would mention that we have found really beneficial for the model is, not all readmissions are avoidable, and so but the ones that we do bring back, we tend to bring back much earlier before they're in a really emergent situation. So we're able to identify that things are going south a little bit sooner with those nurses in the integration center. So that's been a real advantage to our, our providers have expressed that repeatedly, that, it's great to get these patients back while we feel like we've got a little bit more room to intervene. So that's been our experience thus far.
I think it's great. I think you guys are running some really impressive programs. And now we've heard from VCU and Mayo in terms of these robust built out academic center programs. Dr. Connors, you're approaching it from slightly different, and it's very much a pediatric workflow. Could you talk more about the specifics of your programs and how this fits into the greater context?
Yeah, no, I think it's great. I appreciate Dr. Oman, sharing kind of what they're doing as well. And I went to VCU for med school, so I'm partial to Richmond all the way. But no, I think the really interesting thing in hearing from the academicians and thinking about it from an academic model is it's great to hear about lessening readmissions. And I guess the way I think about it as a PEDS-ER doc is, how do we lessen the admission in the first place, right? So I think that's the next move and the opportunity with telehealth, because that spoken hub really could be first the primary care. I'm old enough to know 10 years ago that the primary care was kind of the center. The referral network to the academic institution was the center, and monitoring patients, screening.
I'm confused. I thought that was still the center. No, that's not still the center. My dad's a family medicine doc in Mississippi. He would argue he's still the center.
Yeah, well, I hope he's the center. I mean, I think more and more patients show up as we're hearing, as they show up in the hospital. They show up late. They show up and get admitted. They go to the ICU, and then we try to avoid them getting readmitted. And I think the opportunity to that's fantastic. I'm not, I think that's wonderful. The question is, can we use telehealth to move the continuity of care to the left, right? So can patients reach out to their physician or pediatrician before they get sick, or can they get screened, or can they have preventative care? Can they be, remote patient monitoring of asthma before they come into the emergency department critically ill? All those things are such opportunities, and I think it's just more. I mean, the captive audience that you have in the hospital, and once you send them home, I think is demonstrating that fact. And I think that mantra of, we want to catch things before they become, so difficult, is true across the care continuum. For us in pediatrics, it's a worried mom who can call a nurse and 80% of the time get reassurance and guidance. Maybe needs an ER visit 5% of the time, when they're calling, as opposed to the folks that don't have that access and have to come to the emergency department or go to the retail clinic or the urgent care or the fragmented care and don't get the advice that they really need. So to me, this is a great discussion, because I think care at home is really about, all that care. And I think the hub and spoke model, there's multiple avenues to that. So I think that's what makes this discussion fun. And I hope your dad is still the center, and for most folks, he likely is. But we also know we need primary care to lean in. They've probably been the slower adopters of telehealth. They like kind of the office and things like that. So we're pushing hard to really mobilize the existing folks that are out there caring for patients on the front line and help them embrace digital health, which is it's hard. It's a change. It's a big change. But I think COVID has influenced a lot of that behavior change, and I think we all know patients want it. And now it's a matter of us physicians getting out of their way and being able to be more engaged with them in a meaningful way.
Absolutely.
One of the challenges to what Mick is talking about is as we move care and patients and monitors into their homes, it does push acuity higher to the primary care providers. And so physician satisfaction and burnout and those types of things for providers who those patients used to be taken care of by hospitalists or et cetera, are now being pushed onto their daily panel of activities. And I think that's something that we all need to pay attention to as we make sure that we don't overly burden the primary care practices, but also allow them to experience how they can help their patients in that way. So I think that's one of the new ventures we're going to have to talk about.
Absolutely. So I think I'm just going to highlight and underscore that COVID's been an incredible transition for all of us frontline workers. And we have a lot of frontline workers on the call today and really invested in caring for our communities and the patients. It's been hard. So not only has it been hard because of COVID, but it's been hard because of this digital transformation and the change. And what is this doing for clinicians? And then how do we address that? And how do we have a meaningful conversation about I personally don't like the word burnout. I think it implies all these other things. I like the word resilience and how we really support and develop resilient clinicians, but also a resilient community. So I think we've talked about a lot of really important things, and there's a lot of tech enablement that needs to happen. And Mr. Barden, you're doing some really interesting things. You floated up so many gadgets at the very beginning. I was like, I'm gadget overwhelmed. But tell us about TytoCare and how it enables all of this virtual care that we're talking about, and maybe talk about one gadget and like how it's really novel and how it's important to have these technological integrations.
Yeah, no, it's a great question, Dr. Joe. And I just want to preface, TytoCare is a technology company. We do not offer clinical services. So our bread and butter and focus really is to partner with groups like Dr. Connors, Dr. Oman, Ryan's team, right, to really understand their needs and work backwards from their problems and draw for the right solution sets to really draw meaningful technology into the home or wherever you are ultimately offering the telehealth services. I will say that, from our perspective and how we view health at the home is very holistically. I think too often we very much focus on one individual in that household and where we can draw the most value. But we take a step back and really think about all of the different healthcare needs of that particular household and the different types of services that we can offer to that household. So we kind of take a page out of, the Netflix playbook and really think about how Netflix can offer, different services to different members of the household. And that's really our approach. And although our product is a pretty darn good clinical product with all the various gadgets that you talked to, Dr. Joe, that we showcased at the beginning, it's only as powerful as the services behind it, right? So, we're really limited beyond, just the clinical capabilities. We really look to all these innovative programs, the centers for digital health, like Dr. Roman talked to, that can really empower and offer varying services out into the household. And so a couple, in particular, that I really thought were interesting and maybe more noteworthy given that, we just all went through COVID, but a lot of the beds that we started to see fill up because of the COVID-19 pandemic really required better management of these COVID patients. And so we actually stepped into a number of these programs and partnered with healthcare institutions to draw more of that healthcare into the home and better manage these COVID-like patients and really make sure that the right patient was in the right place at the right time. So this was an incredible way for us to, of course, create better access, better quality, better experience in managing that patient from the home, but also free up beds in the hospital and ensure that the right patients were getting the right care in the right place at the right time. So that's a great example of one where we can really maximize the usage of telehealth, even through, of course, a very tough time with the COVID-19 pandemic. But as a final point, Dr. Joe, I think that the technology is all the means to an end, right? So a lot of our focus was, of course, to enable through clinical capabilities. But now our focus is how do we take all this meaningful data that we've captured over the last 4.5, 5 years and actually start to draw insights for it, right? So we can take the AI machine learning capabilities and draw for more clinical insights around, being able to detect, for example, a wheeze or crackle in the lung, or for example, a murmur in the heart, or otitis media in the ear. So this is really our next phase in our focus area, not just to continue to build out your gadgets that you saw there at the beginning, but also meaningful insights as well in those capabilities.
Yeah. Go ahead.
I was going to say, I mean, I think that's well stated. And I think it kind of combines with Dr. Oman's comment about the physicians, and now we're asking patients to, in some ways gather data and deliver care at home. And for a lot of our patients, it's even a challenge for them to connect to a video. So it's a whole nother list when you start to bring them gadgets into the home and making sure they're using them appropriately and understanding and monitoring and what's a false, things like that. So it's going to take folks like David and Taito Care and others to really ramp the education and usability of the gadgets and make it as easy as possible. So that's one of the challenges we see kind of going forward, because we'd love to have every patient to have a gadget in home. Then it's the next step is how to get them to use it appropriately. And to Dr. Oman's point, once that data flows to the doc, what do they do with it, and can they rely on it? So it's certainly more part of the challenge that we have facing us going forward.
Yeah, definitely. The digital enablement, making sure it's safe, secure, and reliable is strangely 3 very complicated and concepts. So I love all of this. And Ms. Lloyd, from the patient perspective, I'd love to just hear, how has care changed from the patient perspective during COVID? And from your understanding, what's been the most interesting or impactful or valuable in terms of these digitally enabled services?
Sure. I think care has changed just in general, that virtual care and telehealth is now available. And we keep hearing these stats around, patients want this to stick around. And I think that's very true. They want the ability, when appropriate, to be able to see their doctor virtually. And the last 1.5 years has almost set that as an expectation, right? Is, why was I able to do it then and I can't do it now? If that transition happens, right? And I think there will be some education that needs to happen there too, because when we went through COVID, it almost felt like at times everything was fair game to be done virtually, because we were trying to keep people at home and keep them safe, right? So, that doesn't mean that everything is going to be appropriate for virtual care or telehealth moving forward. There will be some adjustment there, but I think we do, as patients, want to have that offered to us when it is, clinically appropriate to do so. So I think there will be a little bit of transition there for sure. I think there's just a huge opportunity, like many of my fellow panelists have said, to just meet the patient where they are. And we've talked a lot about the digital enablement of this. And I think we went through a period where the expectation has been the patient goes to the physician, or the patient goes to the expert or the specialist, right? And you end up in a downtown area, in an urban space, and you have to pay to park and you do all these things. But something fairly unique to my patient experience. And, it's a little bit digital and a little bit not, but health at home to me also means in the community and like around where I live, right? So I typically have to go through a series of imaging each year as my annual surveillance, for example. And my doctor is downtown. And, the expectation was that I go back downtown for the, series of MRIs that I have. Whereas I have a, facility 5 minutes from my home that I could actually have those as well. So continuing to expand on that ability to integrate systems and these virtual modalities and create the interoperability that allows patients to receive care in different ways around their home, I think will continually be really important to patients as well, because it is absolutely not the ideal scenario to have to drive downtown and go in traffic and, pay to park and all of those things that, many that do deter many people from seeking the care that they need sometimes, or doing that test that was ordered for them, because it's just not convenient. So I think that will be really important to kind of consider as we continue to think about what health and hospital at home, means to the patient. And the other thing, well, I'm just grateful that these programs are starting, and I even think a lot about hospital at home, and it's not necessarily, from an expertise perspective, something I'm as familiar with as more of the ambulatory environment as my wheelhouse and where I even worked prior to the AMA. But I've been in the hospital as a patient, and my kind of thing has always been like, there's really no rest for the sick in the hospital. If you're in an inpatient floor, you get rounds happening, you get woke up in the middle of the night for phlebotomy comes in at 4 a.m. and flips the lights on, and so if there are ways to bring that ability to monitor and release someone from the hospital a little bit earlier by having these tools, that's, I think, incredibly powerful. It takes a lot of the stress out of recovery. And honestly, I think can be really powerful for healing for patients, because you're not in that environment where it doesn't always feel comfortable. And sometimes, again, can kind of have a level of added stress to a recovery when you're in that position as a patient. So really just excited to hear all of these different strategies happening, and grateful that we have folks like everyone on this panel to be supporting patients and making those happen for them.
Thank you. That was very meaningful. Thank you for sharing that. So we're, Ms. Lloyd, we might actually be at time. I'm not totally sure. Are we at time?
We got some more time. We can be a little flexible.
We're getting close to time. So as we are wrapping up this panel, I'd love for the audience to, you guys have long comments. So if you have a specific short question that I could read, I'd love to incorporate that in. So please feel free to ask questions. But as we're wrapping up, I'd love to hear from each of the panelists. What do you think has been the biggest impact for you in terms of how care has changed over the last 6 to 12 months? And what are the challenges that you're thinking of? And I know I just said this, and I don't want to just point to someone who's unprepared. So
I'll go. Thanks, Jennifer. So I think, prior to the COVID pandemic, many of us, on this call, we're already the converts, right? We knew that remote care, digital care was going to come and happen, but in the daily operations of a clinical practice, some of the revenue issues that Dr. Kvedar spoke to, but there wasn't as much of a burning platform for people to embrace it as much. So we were all busily building, as I've said in other venues, troughs and filling them with waters, but the horses weren't thirsty yet. And COVID made all the horses thirsty at one time. But what we learned was that patients love getting care this way. It's more convenient. They don't have to stop their life to get care. Providers realize they can still provide quality care and use it as a way almost to triage what the next phase of care for that patient is going to be, to match the actual needs of the patient to the delivery channel, rather than forcing all patients to go through the same channel to get their care. And the opening of the eyes of the providers and patients as well, that care can be delivered with high quality this way, I think is really the fork in the road that we hit that is going to change the landscape going forward.
I love those comments, and I am just going to underscore, did I hear that you said patients have wanted this the whole time, and it was the providers who was kind of putting up roadblocks?
I do think, in the reality, we had kind of a bimodal distribution of provider attitudes. We had those providers who wondered why we weren't doing this more, and other groups of providers just said, why are we even talking about doing this? And now they've all moved on to how can we do it more, better, those kind of things. I think that there was also a similar distribution amongst patients, but I think the patients were more attuned to wanting care this way. In part, if we all put on our non-professional hats and think about the rest of our lives, almost every other thing we do in our lives is done digitally now, from banking to travel to dinner planning to whatever. We're doing that all digitally, and healthcare lags all those other industries in terms of meeting the needs of patients and making it more convenient for them.
So well said. Very well said.
I'll go next. I have a few thoughts just in terms of some of the questions I think that we didn't quite get to and I think are important to have, and then just a little bit of a closing remark from the patient perspective based on an experience I've had. I think it was interesting in Dr. Kvedar's, and we've heard this a lot, but in his talk, we heard him say that payers are worried about kind of the overutilization, right? This is creating an unprecedented type of access where will it be overutilized? Will it increase costs? And, I think Dr. Connors had mentioned that, really the goal we want to see telehealth fulfill is to keep people healthier, right? Keep them out of the hospital,
Absolutely.
keep them out of those acute situations that actually are higher dollar. So I think it will be interesting to watch how we see this evolve, because ultimately we want to see increased utilization because we want people to be more engaged in their healthcare to ultimately not have to visit the emergency room and those other services as frequently, right? And those cost a lot more than preventative care at the end of the day. So that's kind of just an observation and has been something on my mind that's almost sometimes frustrating to hear, because it's, we kind of want to see an up in utilization because that's a positive. That means people are engaged and want to take care of themselves and aren't waiting until the last minute to seek care when it's in a dire or acute situation. But with that, I think it will be important for us to measure impact of these virtual care programs over time. So the AMA released, and this a little bit more my AMA hat, but we released the return on health research that we created a framework that lays out 6 value streams of different ways to measure the impact of virtual care and telehealth in practice environments. And it's different practice environments, different payment models, different modalities of care, and really wanting to look at how is this not only impacting financials, but workflow efficiency, clinical outcomes, access to care, physician experience, and then also patient experience and health equity. So I'll hone in, invite everyone to check that out. We can share some more information about that later, but from a patient perspective, I think the industry has largely relied on patient surveys, which are great, but they don't really get at certain things that actually are going to be really impactful in terms of how successful your virtual care or telehealth programs are. They often lack questions about empathy and how the experience that you had made you feel, and what that was like for patients, for families. It also doesn't really address any kind of social determinants. So what were the barriers to actually accessing care in certain ways? And I think we're really going to need to talk to patients to see what might not be available in their environment, in their home environment, to make them successful at using these tools in their environment, so that we can address that early on. So I think we need to really think a little bit more holistically about how we measure that patient experience to really make these programs successful in practice. And then the kind of last comment I had, I've been participating in one of Node Health's their patient node, and we've been working on exploring the ideal onboarding and offboarding for a telehealth visit, because I think a lot of that was a little bit clunky when COVID started. Everyone was just, figuring out how to see their patients virtually very quickly, and patients were figuring it out as they went kind of on their own too, right? Because we didn't have that opportunity to provide any patient education in the office beforehand or anything like that. But what was so striking to me as I'm sitting listening to this group share their experiences, of patients that they've talked to, that many of the things that they were commenting on were actually things that also happen in the in-person environment. It's like, why do I have to fill out these forms every time I go into the office? Why do I have to answer these same questions? And I was like, well, this really isn't specific to telehealth. So that was really striking to me. And, they're going to be reporting out on some of their findings. But at the end of the day, what that made me think of is this is a very crucial opportunity to just rethink the care experience in general, and how we really create like a seamless, digitally enabled experience for patients and healthcare providers and physicians and care teams as well. But really, it shouldn't feel any different whether you're, going through the process of a virtual care visit or an in-person visit. And some of those things that are not ideal for the in-person visit, let's not just automatically figure out how to bring them into the virtual visit, but rather, how do we maybe take this opportunity to rethink how we approach this in general, and how we approach patient visits and that kind of thing overall. So those are some of my closing thoughts.
I really appreciate that you shared those with us. And I just want to underscore, I feel like I'm a little bit of an old person when I say this, but the original pushback on telehealth was that concept of overutilization. I really dislike that word, utilization, overutilization, because it doesn't get to the heart of what type of connectivity are we creating with our patients? What kind of relationships are we building with them? And is it utilization or is it meaningful engagement? So I think, Ms. Lloyd, to what you were speaking to, which is when we're thinking about what we're measuring, how we're doing it, how we're delivering it, these touch points, are we engaging in such a meaningful way that we're actually getting back to a tighter clinician-patient relationship? This concept of compliance, it's not compliance, is are we meaningfully communicating with them so that we are empowering patients to take care of themselves? And measuring that in a meaningful way is fundamental to this. And I think it's going to drop and there were some data that also, some published data that said, okay, payers, you should be upset. You're going to have to pay for all these X, Y, and Z things. But at the end of the day, it's the patient, our population health, and how we're taking care of the community and doing it meaningfully. Sorry, I went off on a tangent, but Ms. Lloyd prompted me. We have 3 others to hear from, so I don't know who wants to go next in the fairness of a panel roundtable.
Yeah, I could dovetail off that if you want. I mean, because I think what Stacy's saying is spot on from a patient perspective. And I think what we can't lose in this is also the digital divide and the fact that we have to be able to meet the needs of all patients, not just, and we always blame broadband or we'll blame internet connection or things like that, but there's interpreter services, translation services, there's cultural differences, there's affordability of devices and access. Only 50% of kids have a medical home. COVID has, illustrated to us that the system is not working for everyone, whether it's digital health or in-person health. So I think the challenge I see is how do we continue to push to really get everybody access and get everybody the ability to utilize digital health to augment their care. So I have really appreciate Stacy's perspective and the patient perspective. I think it's spot on, and if we keep the patients in view, we'll probably make better choices as we kind of move forward. Because it's almost like you need to look both ways before you cross the street and run over to the shiny object, right? First, we gotta look both ways and make sure we got things covered before we move too fast. Because I think that continuity of care and the patient perspective and how we foster those relationships is critical. So that's my final comment. Turn it over.
Thank you, Dr. Connors. Go ahead.
This is Ryan. Thanks, Dr. Joe. I would just add to everyone's comments. I think, we do have a burning platform in this space right now. I think from a hospital or health system administration perspective, one of the things that we can best do in this space is understand what the value levers are for this model of care within your health systems. And so we understand, as folks have described, we know it's beneficial for patients, regardless of where you are in the journey from volume to value. In most of our health systems, the inpatient discharge is still the primary, financial engine of the health system. And so, as we look at where do we want to invest what are often, tight capital resources in this day and age, it's really understanding that piece of it. So, for some, it might be occupancy, for some, it might be ambulatory access. If you're self-insured, it might mean, managing your employee base differently and in a more cost-effective, patient-centered way. I think, managing indigent patient populations differently. If you've got a high Medicare Advantage penetration, those kinds of things. So I think regardless of where the payment schemes go with this, the model of care is here to stay. We just need to understand how it fits into sort of the financial footprint of your individual organizations. I think would be, something I would highlight as not just a barrier, but also an opportunity, frankly. I mean, if you can really understand where those opportunities are within your organization, particular, as Dr. Oman said, the folks that are on here are early adopters, and we've been bought into this for a long time. But if you have, hospital or health system leadership who may be still on the fence about it, where's it going? I'm going to wait and see. Just understand where those opportunities are for your health system and try to plug in and fill a gap that exists would be my suggestion.
Thank you. And Mr. Barden, we're going to end with you in terms of tech and digitally enable all of these services to be delivered.
Yeah, just a couple of points. I think, to sum up some of the discussion, I think from our perspective, we're extremely excited about the acceleration of telehealth virtual care, especially over the last 18 months. I think the biggest growth area for our particular organization has really been around the payers. We're actually starting to see a huge shift towards more of these virtual first-like plans. And I'm excited to really be part of that measurement of behavioral change, because that's really going to be ultimately the driver and really seeing how much of this care can we really shift into the home. But as a direct kind of challenge to that, right, I don't think the home is always a possibility. I think Dr. Connor has talked to all of the different challenges around telehealth and virtual care. And I think we have to accept that the home is not always going to be a possibility. And that's why we've really focused our attention as well to apply our capabilities to being able to apply it to an employer site, a fire station, right, that's open 24/7, non-traditional healthcare locations in general, schools. I've heard so many incredible stories around schools where in highly dense Medicaid populations, the school sometimes is the only location that a child unfortunately receives care. So it's incredible to see what we can do, and we bring telehealth even to a school location. But even on the traditional location sites, right, like satellite clinics, thinking about rural locations and how we can extend, let's say, all the amazing services that VCU or the Mayo Clinic can offer without needing to have a specialist or even an MD or nurse practitioner having a MA or nurse potentially facilitate through telehealth and connect back into the hub. And we've seen that incredibly impactful, especially for oncology-like patients. So those are a couple of my kind of closing comments and some of the challenges that I see as we move forward.
So as we're closing up, I want to say a big thank you to our panelists. Thank you for, leading the way, driving innovation. I want to say a big thank you to the American Medical Association for putting this together, supporting us, and everyone who's joined us, including all of the clinicians and frontline responders. It's been a hard year, and we continue to change, adapt, and create connections in the community. So thank you to everyone. Back to you, Ms. Lloyd, or I don't know what's next.
Yep. I should have done like costume changes.
We're gonna have some music. We're doing a transition.
Yes. Thank you so much to each of you as panelists, and of course, Dr. Joe, for the great conversation today. We are going to transition into some breakout rooms to allow for additional engagement, interaction, dialogue. We didn't end up doing much Q&A here, but I think the conversation was worth continuing. But you can actually participate in the continuation of this conversation on health and hospital at home in one of our breakout sessions that will be led by or facilitated by Dr. Vimal Mishra, who will help to lead this discussion. He serves as the Director of Digital Health at the AMA and is a medical director, associate professor of medicine at Virginia Commonwealth University. So he provides clinical strategic informatics and research leadership to us at the AMA Digital Health team and the VCU Health programs. So he will be in one of our breakout rooms. We are also really excited to have a few of our Telehealth Immersion Program collaborators participating in the event today with us and leading the other breakout rooms. In these ones, the conversation will explore ways that telehealth is creating value and specialties, including some current and potential emerging use cases, best practices, areas of opportunity and impact. So first, we will have Dr. Rebecca Schmidt, professor and assistant dean at West Virginia University and past president of the Renal Physicians Association, And she will be leading the conversation on how telehealth is impacting the specialty area of renal and nephrology. And then in our third breakout room, we will have Lisa Satterfield. She's a senior director of health economics and practice management from the American College of Obstetrics and Gynecology. And she will be facilitating a discussion around various aspects of telehealth and the opportunities in the obstetrics and gynecology space. So have a few options for everyone today based on what you want to talk about. In a few moments here, everyone will have the chance to choose what breakout room they'd like to participate in. We'll stay in those rooms probably for about 30 minutes or so, and then we'll come back together, do a brief report out led by our facilitators, and then wrap up for the day. So my colleague Laura is sharing our screen about what you will see when they launch the breakout rooms, and then you'll be able to join those. I think that's all I have for the breakout rooms. Any questions before we get started? Give it a few minutes here in the chat just in case. All right, I don't see any questions, so I think we can get started. All right, we'll give everyone a few minutes to get back in the room. Thank you, Audrey, for keeping us moving on that. It was pretty smooth. I'm actually impressed. All right. We are.
So we were having a robust conversation, guys. So thank you for forcing it in here. So that's good.
Yeah, I heard you. You did a whole round of intros. You might have not got too much time to talk. So we'll look forward to some of your kind of closing recap comments. Let's maybe start with the specialties. I know those rooms were a little bit smaller. How about Lisa, you want to go first from the ACOG obstetrics and gynecology perspective?
I sure will. Thank you, Stacy, for having us. And I really appreciated the discussion that the group had, because we talked about what a good space that particularly maternity care can provide for the use of telehealth. And I will be sharing with Stacy some resources. One of those resources is a published study that our clinical director was the second author on how to reimagine prenatal care with telehealth visits instead of the 13 inpatient visits that we're also used to. So I will share that broadly with Stacy so she can get that out to everybody. There are so many things to think about besides just prenatal care, how it can be used for postpartum care, and how telehealth could really impact the maternal mortality issue that we have here in the United States, especially with populations that maybe don't follow up after the delivery of a baby or have a hard time getting into the office for that follow-up. And how can we as OB gynecology providers and support personnel like myself, how can we encourage the use of telehealth, including and not missing those key things that may be going on in a woman's life. There's one way to think about it as remote patient monitoring, but there's also the importance of the relationship for all of medicine with the patient and the provider, and the ability for the physician and the healthcare provider to be able to discern through a telehealth visit that there might be something else going on here, right? That maybe they need a little bit more instruction, a little bit more support, or they might even need to come into the office. So really taking the time to establish that in the telehealth visit for the care of the woman. We also talked briefly about there are situations that women may not be safe. How do we pick up on that? Could we use the community health centers for the telehealth place for the woman to go to so that she can talk more freely about the situation she's experiencing at home. And then again, we talked about which is it traverses all medical care payment, and how during the COVID pandemic, we were able to experience a lifting of so many regulations and payment regulations that allowed telehealth to really take off. What happens after the pandemic? What happens to those audio only visits that we've enjoyed? What happens when payment is reduced for telehealth again? So a lot to work on, a lot to work from an advocacy standpoint from where I sit, and a lot to think about from the OB gynecology workspace as well.
Great, thank you, Lisa. Let's go next to Dr. Schmidt in the renal nephrology breakout session.
Well, thank you, Stacy. We had a small but mighty group, and we, the situation with telehealth and nephrology has is not necessarily new. We had been working on, many of us have been working for a long time to try to assure that there was, appropriate payment for us to be able to use telemedicine, particularly for our home dialysis patients. And I think the pandemic has really been helpful in lifting some of the geographic barriers and other barriers that have allowed us to have increased recognition for the potential for meaningful engagement. I picked up that term today from Jennifer. The potential that for meaningful engagement that telemedicine has for so many types of interactions between patients and their physicians. And the patients that we care for as nephrologists, have a long journey, often from early kidney disease through moderate to advanced declines in kidney function, all the way through dialysis and dialysis dependence. Maybe they get a transplant, maybe they withdraw from dialysis, but there are so many opportunities for using telemedicine in our patient population, both in patients that are not on dialysis and patients that are on dialysis. So, the opportunities that we can have for telemedicine to be utilized involve a lot of logistics. Logistics we talked about are not insignificant, and particularly in states where it's very rural, as in West Virginia, and the challenges with connectivity and poverty and people not having a computer even. They all usually have a smartphone though, or often do, so that we can use those. But those challenges are not insignificant, and we had some discussion about that. I think one of the two, we, in addition to continuing to have to work through these logistic challenges, no matter where you live, two of the issues that we talked about reminded me of other, the national provider slide that Dr. Kavadar showed, where the use of telemedicine had declined among national providers and increased among local providers. I think the discussion we had was, we need to figure out how to make that a win-win for everybody. And the interaction between local providers and the national companies or vendors, for lack of a better word, is going to be needed to help further this and make sure that we are utilizing everyone that in this space that we can possibly utilize to get this done. And at least in nephrology, the last couple of years has seen some very robust and almost challenging goals with regard to the number of patients that we're trying to move to home dialysis, which will have us to need to engage telemedicine all the more. And the challenges that we have with the technology and the infrastructure and the resources can be very difficult, and that interface between technology and the provider and the technology and the patient, there's a lot of things that we still need to work out. And currently we're doing pretty well, though. I think, I know I do a lot of telemedicine with my dialysis patients, and as as we do with these Zoom meetings, we have the dietitian, the social worker, the nurse, and myself and the patient all on the same screen, like the Brady Bunch. And so we're having a visit like this, and the patients are so grateful to be able to discuss things and not have to drive that 3-hour drive often to see any of us. And they're able to mail their own blood work out from their home. And we talk about their weights and their fluid and their treatment numbers, just like we do if they were sitting across the room from us. So, those are the kind of things we talked about. Is I think the most important being the potential for expanding telemedicine even further than we're already doing it, and recognizing how the potential for the meaningful engagements that we can have by telemedicine will help us move it forward.
Awesome. That sounds like a great conversation. And I specifically liked the reference to creating the relationship and using everyone that is a part of this industry, right? And speaking to the national and local providers, because that's often, part of that conversation with those national providers. And Dr. Kvedar mentioned this too, but there is not usually a brick and mortar associated to that. And we know not everything can happen virtually. Not everything can be done via, telehealth. So what happens when someone ends up on the other side of that screen and they need to go in, right? Being able to have that connection between those national and local providers will be really important. Yes, agreed. Awesome. Well, thank you so much for being here with us today. I really appreciate your participation in this and your leadership in this space. Dr. Mishra, you're up.
Great. No, thank you, Stacy. And I think we had a wonderful conversation. We had 20 folks in the room. They were representing, physicians. They were representing health tech companies. They're representing consultancy company around digital health work. They were representing patients. So that was a robust medical association. So really robust presence there. We had rich conversation all around. Everybody gave the introduction and talked about why what is working for them, what program they're working in. And it was really good to hear from a lot of different perspectives. What we discussed during this, and we could not complete the whole conversation around the value of care, but we did kind of get into some of the domains of barriers of telehealth. I think everybody acknowledges overall, vast majority of us acknowledge that telehealth is really helpful. It improves the experience, it improves access, it improves financial and operational effectiveness when measured it right, and the equity question. So the barriers which came was similar to what was presented by Dr. Kvedar, which was around policy. How will this stick? Is this going to go away? That was a question. Big question around infrastructure. So we had Dr. Jorge from Puerto Rico who joined us, and he's working on LTAC there. And he was talking about how the infrastructure is supported, what the internet could look like. Then we have some folks, some of the physicians from the city centers where there are issues with internet and broadband. And the experience we were talking about is how they have to call the patients over the phone, and how do we make sure that the telehealth, as we are implementing forward and moving forward, is equitable. So all those great questions around infrastructure, policy, funding, and equity was brought, and it was really enriching conversation. There was a conversation around some of the relevancy and appropriateness of care, which from one of the patient's perspective, from a policy perspective as well. And there was a rich conversation around it. Thankfully, we had a cardiologist in our panel, and we talked about, the right care, the right time, the right setting by the right provider. So I think there was a conversation around that as well. We did talk about school-based telehealth as well, and how enriching and really improving access to the children there as well. We also touched on a little bit of ET3 model, which is emergency triage and treat model for our ambulance authorities, where the physicians or the ED can directly connect with the ambulance authority and treat in place when necessary and needed. So that was great as well. We also had a great conversation around healthcare with, something which we have not thought, Stacy, around this care for, homeless patients. How does telehealth fit there? Especially, and I think that is the only place because, and the conversation by Dr. Lydia was more about, they don't have a shelter in place. We have to connect with the patients. What's the best way to do this? So lots of different questions, conversation revolving around this equity question came. So in terms of where we could reach with the value of how are we measuring and thinking about value of healthcare moving forward, especially around telehealth, I think there was a very good comment by Dr. Oman around how he thinks about the value of virtual care. It cannot be episodic. It cannot be, hey, this is a fee for service. You did not get paid, so not really. He kind of talked about one example where the patients are saving $1,000 after a surgical procedure because they are able to touch the patient post-procedure, but that is a lost revenue for the hospital. But how do we then holistically think about capturing the value for the system, not only for the one entity? So lots of rich conversation. I think we'll continue to have the conversation moving forward around this. And this is a very complex topic and a very important topic for us to continue the conversation. So I'll stop there, Stacey.
Great, thank you. Sounds like it was a good follow-up to the panel discussion. And yeah, hopefully we can keep the conversation going. I'm gonna have Laura pull up a few final slides so that we can wrap up for the day. But in the meantime, really, special thank you for all of our speakers, panelists, and facilitators today. We're definitely grateful that you chose to spend your Saturday morning with us and really appreciate each of you sharing your expertise, your experience, and your insights with us. As we close today, just wanted to share a few upcoming opportunities to get involved with the Telehealth Immersion Program and help support some of Dr. Kvedar's earlier calls to action. First, we'll be hosting a virtual discussion on the AMA Physician Innovation Network focused on implementing telehealth with an equity lens. This is actually a follow-up discussion from our August program webinar. So you can check that out. It's recorded, it's on the website, and then really just using this time as an additional opportunity to continue that conversation as well. It will kick off on October 11th and run for 10 days. That's all asynchronous, so you can log on at any time within those 10 days to check out the discussion and engage just by asking questions, answering questions, and things like that. Next slide. Then many of you may be aware, I think I mentioned it during our panel discussion. I'm sure Dr. Mishra also mentioned it as part of the discussion in the breakout room. The AMA recently, back in May, launched their Return on Health research that focuses on measuring the value of virtual care across 6 value streams and different practice environments, payment models, modalities, patient populations. So in collaboration with our AMA Physician Grassroots Network, we launched a campaign to collect additional case studies on the impact of telehealth across the country. So we are hopeful that you'll join us in helping to provide the evidence needed to ensure telehealth is here to stay by submitting a case study at the link on this slide. I believe my colleague Meg also posted this in the chat as well, but you will have access to these slides after, in addition to the recording. So you'll have access to this link shortly, but thank you in advance for considering sharing your experience with telehealth and the impact that it's having in your environment. So that is a wrap. We're gonna end about 10 minutes early, which I'm actually okay with because it's Saturday and everyone should get to enjoy their weekend. Thank you so much for joining us today. We really do appreciate all of the engagement and insights that each of you contributed to this morning. And we do look forward to seeing you at one of our upcoming Telehealth Immersion Program events. If you have any questions, suggestions, feedback, always feel free to reach out to myself or Bernadette Lim on her team. She couldn't be here today, but she organized this whole thing, and grateful that it went smooth thanks to her detailed project management. So special thank you to her, even though she's not here. And thank you everyone again. I hope everyone has a really great rest of your weekend, and we will see you soon.